Today's topic is about epilepsy and what it is and what can we do about it. So it serves as an introduction and we aim to create awareness about epilepsy. We'll first start off with introduction to our mascot and ambassador to NNI Fund. On our left, we have Danny. So it's a nerve cell, also what you call as neuron. So we know that neuron on the right, so you can see that there are these electrical wire-like structures with multiple projections on both ends. So these are nerve cells. Together, they form a very complex network for communication inside our brain. So our brain consists of 80 billions of neurons, all buzzing with electrical activities, and is different parts of the brain serve different functions. So just to quote an example, you can see the blue shaded region is what we call as the frontal lobe. So frontal lobe controls language production, controls voluntary motor movement of the contralateral limbs, as well as motor planning, so on and so forth. So the other brain lobes have different functions of their own. We'll not dwell on that at this moment, and we'll move on to the next slide. So this is an EEG, or what we call as electroencephalogram. Electroencephalogram is, you can think of it as the equivalent of an EKG or ECG. So when the electrical signal of the heart can be recorded, the brain electrical activity can be recorded as well. So this graph shows how our brain activity is like when it is in a normal state, when everything is calm. So when everything is calm, our brain activities consist of very small voltage of electrical activities over different parts of the brain. And if you were to compare it with these diagrams, so this graph shows that, just to bring your focus to the middle part of this diagram, you can see very wavy, spiky electrical activities, and this is when a seizure occurs. And a seizure can occur in just a small part of the brain when just a few channels are affected, or the whole brain as in this example, when all the channels shows abnormal activity. So we'll move on to the next slide. So what are the different types of seizure? So seizure can be broadly divided into generalized seizure and focal seizure. So general seizure happens when both sides of our brains are simultaneously involved with abnormal brain activity. And generalized seizures can also be subdivided into two types. The one with more motor manifestation, when the patient has jerking movement or stiffening, that's what we call tonic-clonic seizure, or if the conscious state is affected but without much motor movement, what we call as absence seizures. Focal seizure happens when only a small part of the brain is affected, and depends on which part of the brain is affected, it gives rise to different types of symptoms. So what is normal? What is abnormal? This is a photo of Tokyo Kosei Wind Orchestra, and normal brain activity, you can think of this as when the orchestra is performing well, everyone is striking the right note at the right time, and a seizure is when a focal seizure is when just a small part, perhaps maybe the trumpet is not cooperating, is stressed up, and then is playing in a non-synchronized manner. And a generalized seizure happens when the whole orchestra is in chaos. So just an analogy of what a seizure is like. And I think this analogy sums up how it looks like. And where is the problem? So remember just now when I mentioned in focal seizure, uh, the symptoms differ depending on which part of the brain is involved. So like just how distinct part of the orchestra works. So when things go wrong, um, for example, if let's say if the frontal lobe, the one shaded in blue, is not uh is not playing the right cue, then what happens? Motor symptoms like abnormal posture, jerking at the limb can happen, or speech problem because just now, like I mentioned, is a center of language production. So patient may have speech disturbance or something complex like cycling movement. So um, other parts of the brain, for example, if let's say the temporal lobe is involved, patient may have strange smell. They may have a strange feeling, what we call as deja vu, a sense of uh, more unfamiliarity or a sense of strange familiarities, jama vus, or a abnormal tummy rising sensation. So all these could be symptoms of a seizure depending on which part of the brain is involved. And what could be the trigger? So the trigger can be a local problem, like if let's say the brain is having an infection under stress, under physiological stress, it can experience a seizure. Or if let's say that a patient is experiencing electrolytes abnormalities or having uh, uh, in bloodstream infection, a severe bloodstream infections and all, or if a patient binge drink a lot of alcohol, and when they're having withdrawal, they can also experience seizure. But having seizure alone doesn't mean that you have epilepsy. And I'll drop more into that in a while. So how does a seizure look like? So these are videos that we got from Epilepsy Disorder Journal, and have a look what happens to this patient. So the video is recorded in epilepsy monitoring unit. You can see that there is a 4-speed coding to the left side. And then legs are assuming an abnormal posture. And then it starts with the so the video shows that how it looks like in a case of a generalized seizure. So what is epilepsy? Epilepsy is an enduring tendency for a person to have seizure. So it's not like just one-off event. In this group of patients, they tend to have multiple seizures across time. And the again, a patient with epilepsy can have generalized epilepsy or generalized seizure or focal seizure or both, depending on what we call as what epilepsy syndrome they have. Challenges associated with epilepsy. We do know that epilepsy can have detrimental effect to a person's health condition, mental health condition, as well as sleep. So we know that seizure itself can also predispose a person to injuries, can be a minor injury or can also be a serious injury that result in bleeding in the brain. So it also has social as an implication, because living with patients with epilepsy requires a lot of understanding and awareness about their condition and not to impose stigma on them. So what can we do about epilepsy? Knowing that it's something that is enduring, is going to be affecting a patient's life. So the mainstay of management focuses on lifestyle optimization as well as anti-seizure medication. Majority of the patient can have their seizure well controlled with just these two modalities. Of course, there are some patients who would still have recurrent seizure despite anti-seizure medication and lifestyle optimization or modification. In this group of patients, we will refer them for non-pharmacological treatment, for example, considerations of neurostimulation, vagus nerve stimulation, sometimes surgery, and ketogenic diet. Before I move on to the next slide, just a few key examples of what lifestyle optimization means. So, important things would be good sleep hygiene, as well as avoidance of binge drinking that I mentioned earlier on, and also adherence to, of course, adherence to medication and adherence to appointments with the neurologist. And for some patients who have specific triggers, this is what we call reflex seizure, then avoidance of the specific trigger. And I mean, not too sure if you all know, there are some patients who have more photosensitive, and in those cases, then have to avoid photosensitive stimulants. So medication, anti-seizure medications, there are various types of anti-seizure medication. Each of them have their own advantages and also indication, because like I mentioned, there are different types of seizure. There are focus seizure, there are generalized seizure. Some of them work very well for focus seizure, some of them work very well for generalized seizure. So do consult your neurologist about more details about medication. What are the actions planned during a seizure? So first and foremost, remain calm. Second, to protect the person from harm, so try to remove objects that could potentially cause harm, sharp objects that could potentially cause harm. Turn the patient to one side, or what we call as recovery position after the seizure stop. And importantly, during the seizure, do not force open the mouth or don't put any object inside the mouth. And observe the type of seizure if possible and time and duration if possible. And don't restrain the patients and call 995 if the seizure lasts more than 5 minutes or if the patient do not regain consciousness. Then what are the recommendations for persons with epilepsy? Keep a seizure diary. That is important. That is for you and also for the doctors to keep track of your seizure control and so that we can monitor the treatment. No driving or riding motorbike because it is an offense to drive for someone who has epilepsy. I'm saying epilepsy, I'm not saying that seizure. So the key term is for someone who has epilepsy, it is an offense to drive. And refrain from activities that have potential to cause serious injury or harm if seizure occurs midway. So activity at height or operating heavy machinery or swimming, especially if without supervision. So we have various support for patients with epilepsy, the Epilepsy Group Care Group Singapore. The contact number is below, and the Singapore Epilepsy Foundation. I'll pause for a while. So that comes to the end of my slide.
Thank you, Dr. Q, for an insightful sharing. We shall now address some of the questions from our participants. For those who have missed the QR code to enter the Q&A room, you may still scan the code on the screen and click the link in the Zoom to enter the chat. Okay, for the first question, okay, will the stress caused seizure?
So before going to the answer, I think just a distinction between what stress is to neurologists and I mean to doctors and also to a layman. So stress it can be divided into what we call physiological stress, whereby the body is under stress. And I mean what stress means to layman is more of mental or psychological stress. So these two types of stress can equally uh, trigger a seizure. For mental stress, what happens usually is that I mean when the patient has stress, they have difficulty with sleep sometimes also. So all these can sort of lower the threshold of having a seizure. So in short, physiological stress and mental stress can trigger a seizure.
Okay, thank you, Dr. Q. Okay, the second question is, does epilepsy patient have lower life expectancy?
So in broad term, we are talking about the most type of epilepsies, and epilepsy patients generally do have normal life expectancy.
Okay, third question is there a cure for epilepsy?
So mm, so we have to so epilepsy, we do know that in terms of frequency of seizure, there is a spectrum. So I mean, majority of patients will achieve good seizure control, as in no seizure with just medication and lifestyle optimization. So of course, in medical term, it's not a cure per se, but the disease will be under control with just a single one type of medication for most of the patients and lifestyle modification. Um, of course, we do have patients who have refractory seizure, what we call them, recurrent seizure despite multiple medication. That is when we would consider things like what I mentioned earlier on, vagal stimulation or surgery. For certain type of epilepsy, what we call as mesial temporal epilepsy, surgery can be potentially curable. But I cannot stress enough that we cannot overstate the term potentially cure. So in short, there is no cure per se for epilepsy, but majority of the epilepsy cases uh, can be managed well with modalities that I mentioned.
Okay, there is a questions asking about what is pseudo epilepsy and what's the difference between pseudo epilepsy and epilepsy.
So I think the term should pseudo seizure. So as I mentioned, epilepsy when a patient has enduring tendency to have seizure, and seizure is where there is abnormal electrical activities in the brain. So what is seizures? That means that a person may manifest symptoms of seizure, like movement, like jerking or um, stiffening, blank staring, uprolling of the eyes, catching movement, when there is no abnormal brain electrical activity. So we do see this group of patients, we do see this phenomenon more in certain group of patients who have underlying psychological disorder or I mean or PTSD. Sometimes they may manifest their internal conflicts with all these seizure-like motor activities, but they are not actually true seizure, and of course the patient would not have epilepsy given that reason.
Um, there's a questions about what is ketogenic diet.
So I will talk more about, I mean, what ketogenic diet means for patients with epilepsy. I'm not talking about for weight loss and all. So ketogenic diet is a proven treatment in patients with epilepsy, especially the childhood epilepsy. So it consists of diet that has higher proportion of lipids uh, to proteins and carbohydrates. So typically it's 4:1 ratio, and its aim is to achieve a neuromodulatory effect in the brain, and it should improve the control of seizure. Of course, I won't delve into how what kind of diet is made out of ketogenic diet. I think you all can find out more about this on the various resources. But the important thing is that it is a proven treatment in patients with epilepsy.
Next question is what are the medications administered for, I think, meant for seizure?
So the broadly speaking, the medication administered are anti-seizure medication. So what the purpose of the medication is to sort of bring down the abnormal activities of the brain. So uh, uh, so in our brain there are two types of activities. One is what we call as uh, neuro, inhibitory activities, and the other one would be called as more activating activities. So what happens in seizure then that there's a lot of activating activities. The brain is a constant active state. So the most of the medication they work on either reducing the activating activity, or they try to enhance the inhibitory activity. Um, in broad term, there are various type of medication works on different channels in the neuron or the nerve cells, and I think I will not go into too detail on that.
Okay. Following the question, okay. There's a question asking, what are there any long-term side effects, long-term effects to the medications?
So anti-seizure medication is we have a long history of anti-seizure medication. There are newer medication right now. The older generation medications, they tend to be very, very effective, but at the same time, they do have some long-term effect that we have to monitor. We have to monitor the liver functions of the patient. We have to monitor platelet of the patient, and I mean just for example, and some anti-seizure medication we have to monitor for osteoporosis, or have to uh, uh, watch out for osteoporosis. But the newer generation medications tend to be better now, and some of them have very, very few interactions with even other medication. And so again, it really specific to the type of medication. It's not like one size fits all kind of situation. So do consult your doctors with regards to the medication that you are taking, and also what could be the potential long-term effect.
Okay, next, is there any correlation between
I'll leave
epilepsy and
this
dementia?
question to the next speaker because he'll be talking to us about sleep timeline.
Okay. Okay, there's one more question. So why is seizure getting more frequent than before? Like from once to in 2 months to like once in a week.
So again, we won't go into the specific, but I think again in broad term, we have a few things that we have to consider. One is whether a patient is correct, is taking the right type of medicine, right type of seizure medication. The other thing is taking in the right manner, and also whether there's any interaction with other medications or foods and all, and of course whether there's any like triggering factors a patient is having maybe an infection recently or what. So all there are various factors that can cause uh, a worsening of a seizure control in the patients who are previously well controlled. So again, it have to consult the neurologist on the specific because it's really depending on the context.
Um, is okay. I think in the interest of time, we wrap up our Q&A sessions with Dr. Q here.
Hi, good morning, everyone. Thank you for joining us on this Saturday morning. I know it's quite early and maybe some of you maybe feel a bit sleepy, but hopefully you will enjoy the talk and maybe I will answer some questions about dementia and epilepsy subsequently. So this is the overview of my talk. I think Dr. Q has already covered broadly about seizures and epilepsy already, so I won't really go into detail. But later on, I will focus more on whether epilepsy can cause memory problems and whether epilepsy can cause dementia. And last but not least, I will mention about when to be concerned and what to do, assuming that patient with epilepsy has memory problems. So I think Dr. Q has covered this already. Usually when I explain to my patients, I would mention that seizures are bursts of abnormal electrical activity in the brain. It's like a short circuit of the brain, and that can cause involuntary movement, sensation, behavior, or loss of awareness. So one seizure does not make epilepsy. Epilepsy is a condition when there are recurrent unprovoked seizures. So seizures can be provoked by certain conditions, for example, by medication, low salt levels, and other medical conditions like brain infection. So usually if these provoking factors are removed, the seizures will stop, and that will not be a cause of, the patient will not be deemed as having epilepsy. Whereas epilepsy is a condition where there's recurrent seizures without any known provoking cause. So the manifestation of the seizures will depend on which part of the brain is affected. So over here, I've shown some pictures. On the left-hand side, you can see a picture of the brain, and the various parts of the brain can be affected by seizures. And depending on the part of the brain affected, that can result in different manifestation. So the most common area of the brain that is affected for seizures would be the temporal lobe, which is this part of the brain that is actually near our ear region, right? And that is a part also that is involved in memory. So typically for patients with temporal lobe epilepsy, they may have symptoms like what Dr. Q mentioned, like arising epigastric sensation, or they have feeling of fear, familiarity, what we call deja vu. They could also have abnormal mouth movements, automatisms, loss of awareness, and subsequently, if the seizure spreads to the rest of the brain, they could actually have a generalized seizure, and the whole body could start jerking and all that. So the rest of the brain, like the frontal lobe, like Dr. Q mentioned, or the parietal lobe, they could also manifest as different kinds of symptoms. So for example, if the seizure spreads towards the motor cortex, you can see the blue area of the part of the brain over there. The blue area, leg, trunk, arm, and face. So that's the motor cortex, which is actually a very important part of the brain that controls our arms and legs. So in such a situation, if the seizure activity spreads through those areas, you could see jerking of those particular areas of the body. So it really depends. So some patients may have focal seizures, which means the seizure only occurs for one part of the brain. That is usually a result of some kind of abnormality in the brain. Maybe it's an abnormality of brain development, or it could be, for example, a quiet abnormality like a stroke or brain tumor. Whereas, for example, for some younger patients, they may have genetic conditions that can cause a generalized seizures, which is the seizures that occur from both sides of the brain at the same time. So I think in the bottom of the brain picture, you can see a picture of the EEG. So on the EEG is a test that we do for patients with suspected seizures. And that actually shows us a normal electrical activity of the brain and where the abnormal activity is coming from. So seizures and epilepsy are actually surprisingly not uncommon. So up to 10% of people may experience a seizure in their lifetime. So that's 1 in 10 people. And in the worldwide setting, actually more than 65 million people have epilepsy. In Singapore, the numbers are lower, but understandably, with the aging population, the number of patients with seizures and epilepsy may increase. So we can see that seizures and epilepsy have a bimodal distribution. What we mean by that is that patients in the very young age and the very old age actually have a higher risk of seizures. So this is for the very young, genetic causes are more common. So acquired causes such as brain injury during childbirth. Whereas for the very old, for older folks, the most common cause of seizures will be things like stroke or neurodegenerative conditions such as dementia. So all these can actually increase the risk of abnormal activity in the brain causing seizures and epilepsy. So this is a summary of what I mentioned of the different causes of epilepsy. So for the very young, brain damage from during childbirth or even congenital or genetic causes could cause epilepsy. Whereas for the older age group, things like brain tumor, stroke could cause epilepsy. And any age, severe head injuries will also cause epilepsy. However, epilepsy causes can remain unknown and up to 1/3 to 50% of the cases. So going to the crux of my talk, I think one very common complaint about our patients with epilepsy is that they have memory issues, even despite having their seizures being well controlled. So this is not surprising because studies have shown that up to 50% of patients with epilepsy may have memory problems. Some patients may not even be aware that they have memory problems, but these problems are only picked up during memory testing. But the good news is the memory problems are usually manageable and potentially reversible. So I think first and foremost, when we see patients with memory problems, we want to make sure that first of all, it's not seizure related. So sometimes short seizures or maybe subclinical seizures, meaning seizures without any clinical signs, that could also cause impairment in memory. So like we mentioned earlier, most common area of generating seizures in our brain is the temporal lobe. And the temporal lobe is actually the seat of memory in our body. So if there are seizures that occur from the temporal lobe, you can imagine that the memory can be affected. And during the seizure or even after the seizure, patients may have problems remembering information or even recalling what they did earlier in the day. Once we ensure that the memory problems are not seizure related, then we also need to think about whether it could be medication side effects. So all our epilepsy medications can cause a bit of drowsiness, can cause a bit of cognitive slowing. And we do know that this is dose dependent and also dependent on the number of medications. So the more medications the patient has, that could also adversely affect their memory as well. So there's a fine balance between controlling the seizures as well as managing the dosage and number of medications. Then the third or fourth points I like to mention would be things like mood and psychological disorders. So depression and anxiety are extremely common among patients with epilepsy, can affecting up to 30 to 40% of patients. And we do know that these mood disorders can adversely affect attention and memory as well. So they will need to be adequately addressed in order to prevent memory issues in patients with epilepsy. Last but not least, I'd like to mention that sleep disruption is also a common comorbidity among patients with epilepsy. And we do know that sleep is important for memory consolidation. I think even for non-epilepsy patients, we do know that if we do not get enough sleep at night, our memory, our everyday function, our cognitive functioning will be impaired for the next day. So for patients with epilepsy, it's even more crucial that they get adequate sleep so that their memory problems can be prevented. So that's a broad overview about what is memory. So like I mentioned earlier, the hippocampus is the seat of memory. It is located at the temporal lobe. And when we talk about memory, there's actually different types of memory. So for example, there is short-term memory, which is like RAM in the computer setting. So it's like just like a sticky note. If you try to recall something like a range of numbers or short period, then do some mental calculation, that is known as short-term memory. Whereas long-term memory is also stored in the hippocampus as well. And that is something that maybe we can remember memories of our childhood, what we did long time ago, names of our colleagues. That is also encoded in the hippocampus. So the hippocampus is not just important for memory, it's also important for learning new skills. It's also important for spatial memory, which is like our internal GPS, how we find our way around, things like that. So as you can imagine, if there are seizures that disrupt the normal electrical circuits in the brain, that is like a short circuit in a computer system, and the memory can be affected. So it doesn't mean that the seizures have to affect the temporal lobe to affect memory. Seizures in other parts of the brain can also affect memory because our brain is a complex circuit of networks. So any part of the brain having like normal electrical activity will disrupt the normal circuitry, and that would adversely affect our memory functions. So I'll touch briefly about managing memory problems among patients with epilepsy. So I think first and foremost, like I mentioned earlier, recognizing the cause of the epilepsy is very important because the cause of the epilepsy could be related to memory problems as well. For example, for older patients who have had stroke before and stroke-related epilepsy, the stroke itself could also contribute to memory issues. Secondly, I'd like to mention that I mentioned that certain medications can adversely affect the memory. So, for example, the older generation medications, things like phenobarbital, topiramate, those are actually well known to cause sedation and also cognitive slowing, especially if they are given at high doses that could also contribute to memory problems as well. Then thirdly, I want to emphasize the point that the patients with frequent seizures will definitely have memory problems because you can imagine if you have a frequent short circuit of your brain circuitry, that will affect your brain's ability to encode information, to store information, and for you to recall information. Then fourthly, we mentioned about mood and sleep being crucial to maintaining memory even among patients with epilepsy. So depending on the cause, we will try to target the cause of the memory problem. So assuming that there are, for example, maybe the medication dosage are too high, medications may be able to be adjusted. Perhaps the dosage can be cut down, or maybe the number of medications can be reduced so as to reduce the adverse effects. But this will need to be done in consultation with your doctor because cutting down the medications too quickly to also have a risk of provoking seizures, and that is something you want to prevent as well. So the second point was to control seizures. So sometimes patients may have different types of seizures. So the obvious seizures like Dr. Q showed you, like the flicking of the limbs, blank staring, something that is prolonged, maybe easily observed. But short seizures such as maybe just it could be just a blank out for a few seconds. That could be very short, and nobody may notice those kind of seizures. So we have actually patients who go for EEG tests, they feel totally well, but even though they can respond, they can actually talk normally, the EEG may show seizures. So if we do find that the patients have subclinical seizures, sometimes controlling these subclinical seizures may lead to improvement in memory. But this is of course, in discussion with the patient, because we do know that medications themselves may also affect memory as well. Then last but not least, if there are mood disturbances and sleep disturbances, there could be psychological methods to help to improve these problems. Also, we could also start medications where required to manage mood issues. So now I'll mention about dementia. So dementia is it's a related topic. So it's a decline of a person's mental abilities severe enough to affect daily functioning. So there could be many causes such as Alzheimer's disease, vascular dementia, or Lewy body dementia, or more uncommonly frontotemporal dementia. So it's an umbrella term, and actually what I want to mention is that patients with epilepsy do not actually directly get dementia from epilepsy. So there are other factors that are linked to dementia risk. So actually, studies have shown that up to 50% of dementia can be prevented due to various modifiable risk factors. So things like the education level, lifestyle factors like education level, alcohol intake, physical inactivity could lead to increased dementia risk. Also, health factors such as the cardiovascular risk factors like diabetes, cholesterol levels, brain injury can also lead to dementia risk. And also our eyes and ears, uncorrected visual impairment, uncorrected hearing impairment will also affect dementia risk. So not just talking about epilepsy patients, but even among the general population, these are various factors that can affect dementia risk. And these factors do apply to patients with epilepsy as well. So like I mentioned earlier, epilepsy does not directly cause dementia. However, patients with epilepsy can have a higher risk of dementia. Why we mentioned that is that because some of them may have the same underlying condition causing epilepsy can lead to dementia in the long term, for example. So for example, patients with a stroke or recurrent strokes, many strokes in the past, the scar in the brain to cause seizures, but at the same time, the strokes in the brain will also affect the normal brain circuitry involved in memory, and that could affect their dementia risk as well. Whereas genetic conditions, for example, such as Down syndrome and all that, is actually well known to increase the risk of epilepsy as well as dementia at the same time. Uncontrolled seizures can cause accelerated cognitive decline, and that if the seizures are uncontrolled, certainly the risk of dementia will be higher. And more rarely, seizures can be the first symptom of a degenerative brain disease such as Alzheimer's disease. So this is the chart that later on Mr. Wilbur will also go into greater detail. It's actually showing how cognition can decline among patients with epilepsy. So before epilepsy or seizures start, we know that during childhood there's a normal brain development, but once the seizures begin, it depends on the frequency of the seizures, the type of seizures. So for patients with epilepsy, for example, who are well controlled and they don't really have many more seizures after the first initial seizure, their brain decline, everybody would have a normal aging-related brain decline in cognition. But among patients with epilepsy who have well-controlled seizures, usually this decline would be similar to that of the normal population. However, for patients who have frequent generalized seizures, or they may have severe seizures such as what we call status epilepticus, that could cause accelerated decline of cognition. And you can imagine if you have frequent short circuits happening in the brain, that could actually literally fry the brain cells, and that could lead to accelerated cognitive decline and maybe even earlier onset of dementia. So I think among patients with epilepsy, seizure control is still absolutely essential in terms of preventing dementia. Then, of course, among patients with epilepsy, there's some fluctuating level of reversible impairment, which may be related to medication side effects. And these usually can be controlled by adjusting the medication dosages. So how to prevent memory problems among patients with epilepsy? So similar to the general population, I think physical, mental exercise, social connections are very important. Our diet is very important. So a heart-healthy diet, such as a Mediterranean diet, is often recommended to prevent memory problems. Treating the mood issues appropriately, seeing a psychologist or psychiatrist if there's significant depressive or anxiety symptoms would be helpful. Having adequate sleep, 7 to 9 hours of sleep a day if possible, that's also essential. And one interesting thing is that lifelong learning and education is also very important. So we do know that patients with epilepsy, if they have a higher education level, that could actually have a protective effect against having memory problems in the future. So what are the signs of dementia to be concerned? So these signs are not just for patients with epilepsy alone, but they also apply to the general population. So, for example, if there's severe persistent memory loss, if there are challenges in planning or problem solving, if there's difficulty in doing familiar tasks, these are some of the signs that memory is an issue and you need to seek medical consultation. Other things to be taken note of would be things like confusion with time and place, problems with speaking or writing, decrease of poor judgment, or even changes in mood and personality. Those are also important signs to be concerned of. So this is my last slide. So I'll just mention briefly about how memory problems are evaluated and treated. So among patients with epilepsy, if they complain about memory problems, then we will arrange certain tests as appropriate. So we'll do certain memory tests, such as the mini mental state examination or Montreal cognitive assessment. You could do a mood assessment and sleep assessment. We may do a electroencephalogram, the EEG, if we are suspecting seizures. And of course, if we are suspecting other problems such as thyroid problems, B12 deficiency, we can do the appropriate blood test. Or brain imaging may be done if, let's say, we suspect there are any underlying structural causes causing memory problems. Then there's more specialized testing, such as genetic testing or autoimmune testing if required. So in conclusion, memory problems are common among patients with epilepsy. The good news is that epilepsy doesn't directly lead to dementia, and most memory problems are reversible among patients with epilepsy by adjusting medications, controlling seizures, and treatment of psychological stressors. And it's important among patients with epilepsy to build a cognitive reserve to prevent dementia by getting appropriate diet, exercise, sleep, and forming social connection. So thank you for listening to my talk. I'll now open the floor to questions.
Thank you. Thank you, Dr. Seng, for the informative presentations. Let's now address the questions from the audience. The first question is a lot of people with epilepsy say that they have brain fog or trouble remember things. How can doctors tell if the patient this is just part of epilepsy or started to have dementia?
Yeah, so I think it's a very good question. In fact, this is quite a common complaint that we actually get from our patients. So most of the time we would try to ascertain whether the brain, when the brain fog started, whether it is related temporally to the medications. For example, only after the medication has started, when the patient having brain fog, sometimes the brain fog may be related to the medication itself. And also we want to know whether the brain fog is episodic or whether it is a persistent kind of memory impairment. Let's say if it's something that's episodic, it comes and goes, then we need to be concerned about episodic events such as short seizures that may be causing cognitive issues. Whereas the brain fog is persistent, then we may be more concerned about some persistent issue, for example, with the medication, or we may need to do certain mood screening, such as looking for depressive symptoms or anxiety symptoms, which may also contribute to brain fog. There are other conditions that are actually common among patients with epilepsy or in the general population, such as obstructive sleep apnea. This is a common condition in which there's inadequate oxygen going to the brain at night due to obstruction of the normal airflow to the brain, to the lungs, and then the normal there's not enough oxygen going to the brain. And that's actually a very common cause of brain fog. And we have patients who have this kind of condition. They go for what we call CPAP, some kind of a device therapy to help to improve their airflow, the oxygenation to the brain during sleep, and their cognition and brain fog tend to improve. Okay, that being said, right, brain fog is a challenging condition to manage because I do have patients where do complain of a bit of brain fog. They feel that maybe their memory is not as good as before, but they are still functioning well at work. They're still able to contribute productively to society. And sometimes the condition is just mild, and we've done all the appropriate tests, and we can't really find a reason. Most of the time, we can just observe these patients, and we can just follow them up with doing memory testing, or even send them for more comprehensive memory testing to the psychologist if needed now, to see whether there's a really a significant problem. to be addressed. So I mean, I think symptoms of dementia would be something that would be quite obvious. So for example, if there is persistent memory loss, forgetting things, misplacing things, you can't find the things, or if there is persistent confusion about time, the date, and all that, or if there's a lot of executive function, difficulty with planning, managing finances, medications themselves, that would be something that's a cause for concern. And I mean, this would be a red flag for you to seek medical attention with your doctor. Yeah, but thank you for this question, but I think this is a very important and relevant question.
Okay, the next question is for someone who had epilepsy since childhood and is well controlled, that their long-term risk of dementia differ significantly from general population.
Yeah, so I think so epilepsy is what we call heterogeneous condition. That means there are many conditions that can cause seizures and epilepsy. So let's say, for example, if you mentioned epilepsy since childhood, there are different types of epilepsy that occur in childhood. So there are some developmental and epileptic encephalopathies. Those will occur during the neonatal period or the childhood period. They are usually due to genetic conditions or maybe brain injury conditions. And for these patients, because of their underlying condition, their cognition may be impaired from the outset, and they may have a really fast rate of cognitive decline. So for these patients with a very severe or genetic cause of epilepsy, some of them definitely will have a much higher risk of dementia in the future, or their cognition may be impaired from young to begin with. Then there's another group of patients, for example, what we call the genetic generalized epilepsy, for like juvenile myoclonic epilepsy, juvenile atrial epilepsy. So these patients have generalized epilepsy. The seizures happen from throughout the brain, but they tend to be well controlled. And by and large, although if we do neuropsychological testing, or we may find a bit of maybe executive dysfunction here and there, but very mild, not affecting quality of life. And I think long term, these patients do have well-controlled seizures, and their risk of dementia long term should not be different from the general population. The other thing is that there are also self-limited epilepsy. For example, there's a condition known as SELECT. So self-limited epilepsy with central temporal spike. So these patients with epilepsy, they only have epilepsy for a few years. The epilepsy actually resolves. So these epilepsies don't really have any long-term impact on cognition. Yeah. But that being said, actually a lot of this is still under research, and there's still inadequate data. In terms of follow-up, means a lot of these patients who are well controlled, or maybe their epilepsy has resolved, right? We do not know what is their cognition level when they are 80 years old and 90 years old. So this is something that we know still an ongoing area of research. But based on the available information thus far, generally it really depends on the type of epilepsy that the patient has.
Okay. Actually, I have a question to Dr. Sung. Can I know, are there any specific cognitive rehabilitation programs available for adult patients with epilepsy?
Yeah. So thank you, Dr. Ling, about this question. So for adult patients with epilepsy, if they are seeing us at NNI, I think like I mentioned, we will do a full evaluation to see whether there are any reversible causes of cognitive impairment before sending them for cognitive rehabilitation. So if there are no reversible causes that we can find, at NNI, we have this for adult patients, we have this NNI cognitive enhancement program. This is run by a neuropsychologist, and actually it's a form of group therapy, and it helps teach participants skills to improve their memory on the day-to-day activities. Outside of NNI, in the United States, for example, they have this program known as the hopscotch program. Hopscotch is literally like the game that the kids play, right? But actually, it's a nice acronym for a program that is a self-directed program to improve cognitive ability among patients with epilepsy. So this is a one-to-one program that can be done online and with a cognitive coach. And that can actually, the cognitive coach will actually teach patients with epilepsy regarding about how to simple skills to improve their memory. And also then the epilepsy patient can help to maybe brainstorm with the cognitive coach regarding how to improve their memory, maybe and what their specific problems in memory. For example, they are frequently forgetting things or frequently forget what they want to buy from the market, whether they are simple visualization skills, whether they can take down certain notes, write down on their phone and things like that. And this is like a 6 to 8 week program, weekly run on a weekly basis. I mean, in the longer term, we hope to actually introduce this to NNI, but at the moment, it's only available in the United States. But interestingly, it can be also actually available internationally. So if you go to the Hopscotch website, you just Google Hopscotch epilepsy, international participants can actually sign up for this program free of charge. And I think there are cognitive coaches in the States who can also assist to help patients all over the world. But I think at this moment, this program is only run in English and Chinese or other versions are still not available. Yeah. But thank you for that question.
Thank you, Dr. Shen, for clear explanations. I think in the interest of the time, Dr. Shen will be answering the remaining questions behind the scene later on. Yeah. Thank you. Yeah, thank you, Dr. Shen.
Hello, good morning. My name is Robert. I'm a senior psychologist at Sengkang Hospital. Thanks for the intro. So essentially quite a lot of the things I have at the start has been covered already. So I'll just go through them relatively quickly to some of the things that I think might be a bit more important or relevant or interesting. So we know what epilepsy is. So I won't belabor that point. This has also been pointed out before, but it's helpful to just bring up again. There are generally several different types of epilepsy. You've got the focal, you've got the generalized, and then at the time where doctors and us say we don't know what kind it is. But they do interact with each other. So the focal ones begin in a specific brain region and the generalized ones affect the whole brain. But what we do know also is that it can, the ones that start in a certain region can then generalize and cause mayhem all over the brain. And in terms of the kinds of issues that people with epilepsy face, and this is really where I am focusing most of the talk on, there are several ways we can sort of break it down into the domains of difficulty. So I think cognitive impairment has been talked about at length so far. If you're schooling or working, you might notice also that you're struggling a little bit. You may not be advancing as quickly as some of your peers might be. Mental health difficulties are definitely an issue. Comorbid medical problems as well. Sleep problems are one of them. Substance misuse could also potentially be a problem. But on the sum, essentially what happens when you have all of these things is that the quality of life is a lot poorer for someone with epilepsy that is not well controlled. So just a bit about the cognitive impairment and epilepsy. It's been known for quite a long time. And this is a little bit of history I always found very interesting and kind of the thing that got me into the profession in the first place. There's this guy called HM who unfortunately is no longer around. In about 1940s, I believe, the case was published. He had a history of very poorly controlled seizures. And around the age of 27 was when he underwent this experimental surgery. I think for the first time, they decided let's just cut out large parts of the brain and let's see whether this manages the seizure. There was a good and bad side of things. The seizures were controlled, but what they realized after that was that this guy cannot learn anything new. There was a very severe and profound memory problem, which I think taught the field a lot about the importance of managing seizures and also how the brain and cognition, the relationship between parts of the brain and how the brain actually functions. So he's probably the most researched person in the history of psychology and neuropsychology specifically. And I guess the legacy has continued on today in terms of other types of research. And from there, where we come, and up to this point, I think the prevalence of cognitive impairment in people with epilepsy varies from study to study and place to place. But in general, we do know that it is quite a common problem. Up to maybe about 7 out of 10 people will have some form of cognitive issues at some point along in their lifespan. And a lot of it really depends on where the brain, where the seizure focus is in the brain and what part of the brain is affected. So I'll cover this briefly because I think it was covered a little bit earlier on as well. You have the frontal lobe. The easy way to think of this is that it's the CEO of your brain. It's the part of the brain that basically gives a vision and say, okay, this is what we're going to do. There's a part of the brain that's also involved in movement. So your hands, your legs, your mouth, the control and basically the voluntary action of these body parts all depend on the frontal lobe. And the rest of the brain, we can think of them as the posterior part of the brain, and they're doing different things, but they all coordinate with the frontal lobe. So the parietal lobe, we kind of call that the integrative part of the lobe of the brain. So it holds information together and it puts it together, sort of like figuring out the different parts of a jigsaw puzzle to sort of see, okay, this part needs this part needs that, where does it go? There's a strip there, the big in green, which also processes sensation. So like if someone pokes you on the skin, that the part of the brain will light up and that's how you process that feeling. The occipital lobe in red, I think this one, not much that I need to say. Essentially, it's for processing things that you see. So visual information that comes through your eye goes to this part of the brain, and that's how you make sense of what you see. People's faces, things on the screen, words, stuff like that. And the temporal lobe is probably the one that's been most studied in epilepsy or epileptology in general, because the types of cognitive issues that come from temporal lobe epilepsy is very varied. Memory is, I think, has been mentioned quite a lot earlier, but also things like language. So you might notice trouble in terms of understanding what people are saying, or even following a conversation, coming out with the word say, or like sort of the meaning of certain words or things you might have trouble with, or even like people's backstories and biographies. And also emotional processing is in the temporal lobe. So it's a small little part of the temporal lobe called the amygdala, which is right in front of the hippocampus. So they're all very closely connected. So the types of issues that you might see, you can kind of break them down into 5 different broad domains. So processing speed is probably the easiest one to understand. So essentially, when you take information in, you do it at a certain speed. And everyone is a little bit different in this regard, but people with epilepsy and certain types of epilepsy, they are generally a little bit slower. So this might affect you in terms of having conversations. You might feel that people are talking a little bit too quickly. You can't catch up, or in terms of switching between task 1 to task 2, it takes a little bit more time to sort of settle yourself in and figure out what's going on. In terms of attention, and this one is very common, I think, in a lot of people with epilepsy, kind of explains a little bit of the brain fog kind of phenomena as well. You can kind of split attention into 2 or 3 different types. So you've got sustained attention, which for simplicity's sake, you can think of it as concentration, like how you're now sitting down, you've been sitting down for the past 1 hour and concentrating and listening. That's what sustained attention is. So focusing over a long period of time. You've got selective attention. So now just imagine, right? You've got a screen in front of you. You might have your partner next to you. There's maybe something in the background. There's a window. There's some tree. There's lots of things going on around you. But you're probably only focusing on my face and the things that I'm saying or whatever is on the slide. So that's selective attention. Your brain's ability to just pick and choose the things that you want to focus on at that point in time. So trouble there might basically result in being quite distractible or having trouble focusing on the thing that needs to be focused on at that point in time. And multitasking, which I think everyone knows, holding too many things and trying to do too many things at once can be affected in people who have attention problems as well. So learning and memory, this one has been covered at length so far. But broadly speaking, we can think of memory in three parts. You've got the encoding or the learning stage, you've got the storage stage, and then you've got the retrieval stage. The easy way to remember this is think of a warehouse. So the warehouse is where you store things. The encoding part of things is the people bringing in the information to the warehouse. And the retrieval side of things is where the workers bring out the information that's in the warehouse out. So problems can happen at any one point of the along this process. So if you don't have enough workers bringing stuff in, nothing gets learned, because nothing goes in. And if nothing is inside, you can't pull anything out because there's nothing inside. On the other hand, people might be able to learn things, so you can store stuff, but if you don't have workers who are bringing the things out, you won't be able to remember it anyway. And then the last scenario, for example, is if the warehouse burns down, but the workers are still around. They've got nowhere to bring the information. So memory problems can happen in different parts along the memory process and can be caused by different things. It's difficult to pinpoint which one based on simple screening tests. So usually the way to get about properly assessing this is a more formal comprehensive neuropsychological assessment, which is sort of where people like me and my colleagues come in now. So the next one is processing verbal and visual information. So language problems I've mentioned before, comprehension of thinking of the words to say, forgetting names, trouble remembering names, things like that. They're more common in epilepsies that affect the left hemisphere in general, whereas visual processing problems usually are a little bit more common in epilepsies affecting the right side of the brain. So there is a little bit of that left and right brain split, but it can get a little bit more complicated depending on when the epilepsy started. So for example, if you were very young and the epilepsy started at that point, your brain might have reorganized such that the way your brain processes information is a little bit different. And finally, you've got executive function difficulties. And these ones are primarily frontal lobe based. Essentially, like I said before, it's all about organizing your mental state and thinking about the tasks that you want to do. So organizing things, planning, reasoning, weighing stuff, it's all very frontal lobe dependent, and it's a very broad range of abilities to come to executive function. And these things can be quite severely affected in frontal lobe epilepsies and can lead to pretty disastrous results in schooling and work, family life, relationships, and so on. So broadly speaking, if you're a child, there may potentially be a bit of a developmental lag compared to your peers, depending on when the epilepsy started and the kind of epilepsy and the type of control you have over the seizures. And the consequences are cognitive issues, perhaps low IQ, reduced academic and potentially occupational achievement of the type of job that you find yourself in. You might also experience social communication and socialization difficulties. And on the other end, as you're sort of heading towards your 70s, 80s, and much older, the risk of decline is also a little bit higher. And so the risk of dementia is therefore also a bit higher. The risk factors are as such, I think they've been covered previously, so I won't mention them too much. But the way I like to frame it are to think about the ones which are disease related, which is not really something you can do too much about for most of them. Medications, you can try to control the frequency and severity of seizures. Person-related factors, there are things which might be a bit hard to control as well, like age, you can't change that. Cognitive reserve, yes, you can go to school, but a lot of it usually tends to depend on the amount of schooling you have in your younger childhood days and not so much when you're older. But there are other modifiable things like mental health issues, sleep difficulties, and other medical concerns or health issues that can be addressed also. So on the mental health side of things, 1 in 3 people with epilepsy have some kind of mental health issues. The common ones are anxiety and depression in all ages, and in children, ADHD actually is a pretty high, it's a pretty common one as well. So sometimes it's not a problem, sometimes it is, and usually we start thinking of it as a problem when these issues, the slow mood or these worries, are very persistent, and it's persistent over a long period of time. And when it starts to affect the person's ability to go about their day-to-day stuff. So the person isn't doesn't feel like getting out of bed. Things just are not enjoyable anymore. They keep worrying about everything all the time. And the things to do for that is speak to your doctor. Psychotherapy or counseling can be helpful for these things. And also these can be managed by medication. But this needs to be carefully discussed with your doctor because you don't want to be taking medications that are not suitable with any anti-epileptic medication that you are already on. So sleep is also a common problem. Insomnia, waking up from sleep, sleep apnea, feeling very tired in the daytime. And sometimes people might even have some fear of actually going to bed because they have seizures. They know they get seizures when you go to sleep. The trouble with this is that seizures can cause sleep problems, but then sleep problems also raise the chance of you getting seizures. So sleep is actually a very, very important thing to have for someone with epilepsy. And as we know, the seizures and epilepsy can lead to these issues. And lifestyle problems that contribute to sleep other than epilepsy are things like taking caffeine, sugar, even smoking or nicotine. Certain medications that you take, like epilepsy drugs, can cause sleep issues because they tend to make you drowsy. And if you take naps or long sleep for a while in the day, you might have trouble going to sleep at night. Use of electronic devices like your handphone and things like that, they do emit some kind of blue light that tricks your brain into thinking it's still morning or not yet nighttime. So that can keep you up as well, or just being, scrolling through your Facebook videos and all that. It keeps your mind a bit too stimulated to help you go to sleep. And the last one, in terms of work, sometimes we have to work shift, and that can be very difficult, especially the shift work is not consistent. You're doing morning, break, night, break, morning. That kind of dysregularity makes it very difficult for your body to acclimatize to a routine sleep schedule. So things to do are sleep hygiene. So there are a few here, but it might be helpful just to go to the Health Hub website where there's a long list of sleep hygiene strategies that you can try. But of course, you can speak to a doctor or basically anyone about this. A lot of these are available online. So in summary, epilepsy causes several behavioral types of problems, like sleep issues, cognitive issues, mental health issues, and academic or occupational problems. I didn't cover the substance misuse and medical health issues, but you can imagine that sometimes if you're very stressed, you might turn to alcohol, and that can lead to other types of problems. And overall, quality of life is quite reduced. So I guess the thing to note here is that if you have epilepsy, the one thing that we want to do for sure is to get the seizures under control, to really manage all these things, because you don't want your life to be difficult. We don't want your life to be difficult. So yes, please consult your doctors if you feel like, the seizures are getting a little bit out of hand. So that brings me to the end. Thank you very much.
Okay, thank you, Mr. Koh, for the enlightening presentations. Let us go to Q&A session. First question, you mentioned epilepsy affects cognitive, I think, decline and higher risk of dementia. Is there any way to reduce the risk of dementia or prevent impact on cognitive decline?
Yeah, thanks for the question. I think very important and helpful question. This kind of is in two parts. So there's the cognitive delay and then there's science. So I'll talk about the delay side of things first, because I presume you are referring to the developmental delay or the picking up the learning of skills. So what we do know is your brain is constantly growing and it takes about 25 years to mature, with the frontal lobe being the last to mature. And if you have epilepsy at a very young age, you can imagine that the continued development and rather the maturation of your brain at that age will be affected depending on the type of epilepsy, the frequency of seizures, the severity of the seizures, and that can potentially cause pretty disastrous effects. So I've seen patients as young as 13 or 14 who are struggling in school. They can't pay attention, they can't remember anything, they have ADHD, and alongside that, their seizures aren't really well controlled. And even in some cases, the seizures may already be well controlled, but it wasn't at the beginning. So think about when you go to school, right? When you're learning all these things, you need to focus, you need to listen to what the teacher is saying. And if you're not able to do that, you won't be picking up stuff. Or alternatively, if you've had issues in terms of processing what people say, things that they teach you goes in, but not, you don't really understand. So when you compare a child with epilepsy who has these kinds of issues to someone who does a normal, healthy child, you would expect there to be issues and problems. The way to go about this is you need to identify what the problems are. And then ideally, it's about working with the schools to provide as many accommodations or supplementary assistance as possible. So when I was at KK a while ago, I think that's what we did. We would perform assessments for these children, and we would try to, as best as possible, to liaise with the teachers and the school, or maybe in certain cases, write into SEAD for exam accommodations and things like that. Ultimately, the aim is to try to provide the child with the best possible platform to achieve whatever is possible for them. In some cases, that can be quite difficult, depending on the type of cognitive issue that they have, and also, I would say, whether it's reversible or not. In which case, then I think a lot of it is engagement with the parents in terms of trying to get the child as much support as possible, and potentially even moving them to a school which is perhaps a little bit more suitable, which can be difficult for some parents at that time. On the other end, in terms of decline and dementia, there are certain things that you can do. So a lot of those lifestyle risk modifications that you can do to reduce dementia risk, it's the same thing in epilepsy. The only thing I would say that's unique to the population of epilepsy is you do really need to get the seizures under control. It's because what happens if you don't is that the parts of the brain which are affected will continue to just, for lack of a better term, die off. And that puts you at a lot higher risk for dementia.
Okay, the second question is, if a person with epilepsy is struggling with mood, should they talk to their neurologist first, or can they see psychologist directly?
Yeah, so this one's a little bit more of a procedural thing. Okay. Also depends on whether you're thinking about public healthcare or private health. Okay. If you go private, you can just go to a psychologist directly. In a public setting, you usually will need to speak to a doctor first to get a referral to a psychologist. Things may change in the future, but at the moment, that's the process. So if you're considering something like this, you can speak to your neurologist who can then refer you on. Alternatively, you could maybe even seek out, if you feel like like you don't really need such intensive type of therapy, you could even seek out maybe counselors in the local FFCs and see if they're able to provide that kind of support that's needed.
I think this will be the last questions. How can a person with epilepsy explain mood or behavior changes to the family members who might not understand what's going on?
Yeah, this one is a tricky one. Thanks for the question. It's tricky because it really depends on the family members and the friends that you have. Some people don't think of epilepsy as really affecting mood, behavior, personality. It's just sort of, oh, okay, you have epilepsy and then you're just having a fit on the floor or something like that. They don't really see what's inside and sort of how it's expressed. So it can be very difficult depending on who you are and who you're talking to. I would say sometimes if you are engaged with medical professionals or even a psychologist or counselor, it might be helpful to have a family conference so that you don't have to be the one sort of pushing the narrative so much. You can kind of get the healthcare professional to come in and then do a bit of the explanation for you. But that, again, is tricky depending on whether the family member is even open to that. There are resources available, Epilepsy Foundation, and a couple more local ones I can't really think of at this point, sorry. But you could perhaps point them to these websites where they do have info sheets or fact sheets about the kind of issues or difficulties that people with epilepsy face. So those are perhaps some ways to go about it. But I think for starters, It's probably just about opening the conversation and just saying, epilepsy isn't just about this. Sometimes it's affecting my mood. The medications make me very drowsy. I'm not interested in doing these things. Sometimes I'm very sleepy. I'm struggling with this. And perhaps it's sometimes about just being willing to open up to whoever you're speaking to. But again, I recognize that depending on the family dynamics, that can be tricky.
Okay. I think we have come to the end of the NNI online epilepsy awareness. Thank you, Mr. Koh.